Hi everyone, this is another tutorial for the MB/BS Year 4 students. This is a topic which my acute medicine students will know I'm very passionate about, and that's the topic of frailty. No matter what specialty all of you want to go into at some point, I think it's important to realise about what being old or elderly means to people these days. It doesn't mean what we perhaps think it might be, and it's important to realise that no matter what specialty you're in, we're all going to be geriatricians. So, for example, if you want to be a surgeon, then you're going to have to be having to think about what type of frailty states your patient has and whether they're suitable for surgery or not. If you're an anaesthetist, about whether you're going to anaesthetise them or not. If you're a medic, whether you're going to escalate their care or not, and so on and so on. So the practice of care of the elderly, medicine and frailty is an important specialty for all of us. So, first little exercise for you, I want you to have a think about what it is that could make you frail. Now, when I did this with some of you in PFP, we had suggestions from trauma to being hungover to falling over and breaking your leg. With patients, we had things like sort of chronic disease states and so on. So I want you to have a quick look at this chart, and I want you to perhaps get into a good habit, particularly in acute medicine, of assessing what your patient's trajectory of disease is. So is it that they are, and I'll show you what I mean by some trajectories in a moment, but whereabouts are they? For example, are they at the beginning of chronic disease? Are they in the terminal phase? Do they have permanent restrictions or inactivities of daily living? Or do they need continuous support? Are they from a nursing home? Are they from a care home? And these things are really important determinants in deciding about what's best for a patient, i.e. level of care and potential treatments such as chemotherapy or surgery. So when we think about our functional capacity and we think about what we do at our age and whether we have any frailty or not, well, for the vast majority of us, we don't. We will have full functional capacity and will be otherwise known as robust. Now, for example, the anecdote that I told when we did this in PFP week was when I was at anaesthetics SHO and broke both of my arms in a cycling accident, had to have surgery and K-wires put into my hand. So obviously that was a significant stressor, but I was almost made a full recovery and I never quite got back to normal. So for example, I have arthritis in my right hand. So even those of us who are robust can undergo significant stresses. And to give you more details about it, I had to have, for example, a full care package as I had both my arms in plaster of Paris, and you can imagine all the rest, I'm sure. Then you sort of potentially have a decline to pre-frailty. So it might be that you have early signs of malignancy, and so you've lost some weight, for example, you're malnourished, and then you may have, for example, go into frailty where, let's say, for example, you have chemotherapy, for example. And so obviously you're quite frail in that sense. You're at risk of neutropenic sepsis, lots of weight, had the associated symptoms with chemotherapy, and let's say unfortunately that chemotherapy hasn't worked and you have a permanent degree of dependence or disability, which isn't a word I like using particularly, but you have a high degree of dependence in the final phases of your illness, and therefore you can plot the trajectory of the patient's decline fairly easily. One way of doing this on the acute take is I will ask my patients to compare themselves to 2 points, a fairly recent point and to one about a year ago. So for example, where are we now in April? I might say to your patient, okay, so have a think about how you were at Christmas just gone, so 4 months ago, and then ask them to compare themselves to say summer of last year or even the Christmas before. And I'll ask my patients to sort of grade themselves, if they like, sort of worse, about the same, better, and just to sort of explore their perspective a little bit. And that's a really powerful tool of understanding what the patients understand about their own frailties, their weaknesses, their level of robustness, their attitude towards their disease, and that can be a really powerful tool if you have to have discussions about difficult decisions or limitations of treatment. We were talking about, trajectory 3 that we were talking about before, where the patient sort of has a sort of fairly sharp up and down decline, and this would be sort of chronic illness and so on. Now, as time goes on, you have increased healthcare use, which of course increases NHS expenditure, high risk of health outcomes. So, for example, a patient comes in for a relatively minor medical problem, but unfortunately develops, say, hospital-acquired pneumonia or hospital-acquired infection, causing disability and a risk of death. It's really important not to underappreciate the input of psychological frailty. So loneliness can be a very difficult problem for any of us at any age, but particularly if you are older and have reduced or restricted mobility, for example, that can significantly worsen the risk of depression. And I often find that we are much better at diagnosing urinary tract infections in the elderly, even if they don't have one, and much harder to diagnose depression, which is much more common because of the difficult subjects you have to talk about. And you'll often find this idea of stoicism, where patients are very reluctant to talk about what makes them frail or what makes them depressed. So some of you may be familiar with this. So this is also in the COVID-19 guidance for decisions about escalation of care. This is a clinical frailty scale, and again, I suggest that you become familiar with it. Again, it's a really powerful tool to sort of categorize patients about where they are in their illness. So, for example, clinically frailty 1 is a very fit patient who is robust, active, energetic, motivated. They are among the fittest for their age. Then you start to get to mildly frail, so these are people that often have evidence of slowing and need help in higher order activities of daily living. So, for example, finances, budgeting, transport, heavy housework, managing medications, and so on. Typically, mild frailty progressively impairs shopping and walking outside alone, meal preparation and housework, through to terminally ill, where patients are approaching the end of life. This category applies to people with a life expectancy of less than 6 months who are not otherwise evidently frail. Scoring frailty in people with dementia, the degree of frailty corresponds to the degree of dementia. So common symptoms in mild dementia include forgetting the details of a recent event, though still remembering the event itself, repeating the same question or story, and social withdrawal. In moderate dementia, recent memory is very impaired, even though they seemingly can remember their past life events well, such as the war, for example, or their engagement or marriage or something like that, and they can do personal care with prompting. In severe dementia, they cannot do personal care without help. The clinical frailty scale is applied across different disciplines and can be very easily found on the internet. Another way of looking about what combines to frailty are the different sort of phenotypes, if you like. So, for example, arthritis, asthma, COPD, CKD, hypertension, ischemic heart disease, bone disorders such as osteoporosis, peripheral vascular disease, skin ulcers, urinary incontinence. So there are numerous disease states that become more common in the elder person. Then you have the symptoms and signs. So patients present with dizziness, shortness of breath, falls, memory, cognitive problems, polypharmacy, sleep disturbance, urinary incontinence, weight loss, and anorexia. You may find a new trend or abnormal laboratory values such as anemia, hematinic deficiency, so B12 folate, sometimes known as the tea and toast diet. You may find the patient has disabilities such as activity limitation, being housebound, hearing impairment, mobility and transfer problems, requirements for care, social vulnerability and visual impairment. Now, I've put on the slide here about the word institutionalized, and this can be a very difficult thing to tackle with the patient. Patients who are vulnerable or are dependent, for example, or have significant comorbidity, often find the hospital a place of safety and sanctuary. So, for example, if you are psychologically frail, then the fact that you have nursing staff that you'll know, ward team members that you'll know, doctors that you'll know, domestic staff that you'll know, you'll have routines that you recognise, food that you'll recognise and know, sleeping arrangements, jog rounds. So all of that sort of familiarity and routine and seeing obviously nurses that have cared for you often can be a positive benefit to the patient. The negative of that, of course, being is that because they get very used to this, when we try and get them home, mobile and independent again, that sudden change in routine again can make the patient often feel very vulnerable or frightened, and that's often where failed discharges come in. It's not that they're not medically fit to go home, it's just simply that the ability to cope being at home, having been in hospital potentially for some time, is a real struggle. So let's talk a little bit about the physiology of aging. Now, some of you may have heard about the concepts of biological versus chronological age, and this simply means that, for example, in chronic liver disease, you might see someone who is chronologically 35 but biologically much older, and this would be because of their cirrhosis, hematological factors, diet factors, and so on, the osteopenia, the avascular necrosis from the alcohol intake, and so on. So you'll have the individual and environmental factors which influence the rate of aging and degeneration, and that includes everything from exercise to diet. When thinking about potentially resuscitation and airways, there is a decline in cartilage and muscular support for the upper airways. So if you think about resuscitating someone, if you think about my PFP talk, where you've got someone who's got very difficult floppy airways, as you'll know from that talk, it's going to be very difficult to put a tube into situ and ventilate them quite harder. And if you imagine if your patient has no teeth in, then basically you're trying to, you pardon the expression, trying to resuscitate almost like a floppy bag, and as you can imagine, that's quite a tricky thing to do. As patients get older, they get less sensitive airway reflexes, cough can be weakened, and sometimes actually if I'm worried about patients and I'm thinking about where they might go to ITU, I'll try and ask them to take a big cough as possible. Although it's not overly scientific, if you've got a patient who has a strong cough, then they are likely to have preserved airway reflexes, they're likely to be able to cough up their secretions, which means potentially they'll do better. If you've got someone who's a very weak cough, then intubating them will only worsen that problem, and they will have long-term risk of aspiration and feeding problems. You often see mild emphysema in the older patient, which is a cumulative effect of long-term aging. You get a progressive weakness of respiratory muscles, about 15 to 35%, and with increasing age you basically get a progressive deterioration in lung function, and that's quite important again when you're considering the merits of intubating someone or putting them, for example, on CPAP. The heart function is similar to the flat part of the Sterling curve, and you may wish to revisit Principles of Acute Medicine tutorial or Shock, which has a Sterling curve in it. You also get calcific and fibrotic degeneration of the conducting pathway, so for example the most common arrhythmia being AF, and you'll know that basically the older the patients get, the more common AF becomes. You get a slowed intrinsic rate, so preserved sympathetic tone. If we were to do echoes on every older person, we'll find that the valves are often calcified, thickened, and that mild mitral regurgitation is common. So here's an example of the Frank-Starling curve in the older patient, and you can see that the older patients low in that area, similarly to heart failure, and are at higher risk of pulmonary edema. So that's why we talk about fluid overload. It can be very difficult to manage the hypotensive patient who's elderly and frail. You have to consider fluid volume, and they are likely to have peripheral vascular disease, mitral regurgitation, possibly outflow obstruction, so from aortic stenosis, also pulmonary disease such as right-sided heart failure or secondary pulmonary hypertension from severe COPD, where you need to be really careful about how aggressively you fluid resuscitate these patients. It's very easily to tip an older frail person into pulmonary edema, as shown by this diagram. So other things to think about is cerebral blood autoregulation is well preserved in healthy or elder brains. The parasympathetic system declines with age, which will contribute to postural hypotension. Therefore, it's important that all patients presenting with falls and dizziness, particularly if older, have a lying and standing blood pressure. Looking to the kidneys, there is a progressive loss of nephrons, so you have a reduced creatinine clearance, but the serum creatinine does correlate with a decrease in muscle mass. Like all of our patients, frail or non-frail, there is a risk of malnutrition, and this is particularly, of course, prevalent in those who are frail, and this often will increase the risk of complications in hospital or post-operatively. You also have a slower excretion of acid loads, which is increasing the risk of hyperkalemia. So again, in that you want to consider your medications to your older patients much more carefully. The body temperature of older patients can be as much as 1 degree Celsius lower. Shivering typically occurs at 35.2 degrees compared to a younger adult, which is at 36.1. You have a blunted febrile response, and that's why it's always important to consider occult infection in the elderly or hypothermic sepsis. Osteoporosis is common, and obviously there's a risk of fracture, there's an operative risk, the need for rehab, social input, and intermediate care stay. So thinking about surgery, obviously in my time in ITU, I had to admit patients post-operatively who were frail, or consider whether I would admit them to ITU for surgery. And there are a number of things that we want to have to think about and plan for. So first of all, preoperative care. Again, this is something that in the emergency situation there isn't much we can do about, but certainly in the elective setting, we want to review the patient's nutritional status, their cardiovascular performance. Sometimes we'll perform a CPET test, and if you look in any good anaesthetic textbook, you can read about CPET testing. Does the patient need an angiogram, for example? Do they have a lesion somewhere that would be benefit from repair prior to performing surgery, which might cause strain on the heart? And their admission requirements, do they need to come into hospital, for example, beforehand, and will they need to go to post-op HDU? Hospital suitability, so we're going to perform their surgery in a specialty centre or in a district general hospital. Can they have that surgery as a day surgery? What might they need post-operatively? So will they need to stay in hospital? Can they go home the same day? May they need to have a short hospital stay followed up by a reablement care package? As I've already said about the need for HDU and ICU post-op. Discharge and rehab planning, so for example, will they need physiotherapy for 6 months? So let's say they have an orthopedic joint replacement, they're going to obviously need focused discharge and quite aggressive physiotherapy. Can the patient consent for their operation? What do they understand about the risks, the benefits? What is it that they're hoping to achieve? What difference does the surgeon think it will make in their quality of life? And this is perhaps more important, what's the patient's perceived change in quality of life by having the surgery? What are their anaesthetic options? So a lot of patients who are frail, we will do under a spinal injection. Some such operations such as hernia repairs can be done under local. Others, such as a major laparotomy, may require general anaesthesia. Sometimes what patients and families can struggle with is that there may be a decline in cognition post-surgery. Now, this is a very difficult thing to predict or quantify, and so communication is key. And what's really important, particularly thinking about my time in intensive care, is to ask the question about whether the patient and their family have realistic expectations of what it is the surgery and ITU are going to do for them. So surgery in the older patient has a risk of significant pulmonary complications. So those aged between 60 and 69, there's double the risk. 70 to 79, there's triple the risk. And there's those about 80 have a 5.6 higher risk of developing pulmonary complications. These might include atelectasis and community-acquired pneumonia. Those who have an ASA greater than 3, abnormal chest x-ray, heart failure, arrhythmia, pre-existing functional dependence, COPD, weight loss, smoking, impaired sensorium, corticosteroid use, and alcohol use. So I'm going to talk a little bit about prescribing perioperatively. So what you often struggle with perioperative medicine or the procedure, many patients fail to receive essential medication, And we often find that when we try and explain pre-op fasting, we don't do this very well, and we often overly starve patients, or we fail to prescribe them essential medications such as anti-Parkinson's medication, HIV, retroviral therapy. So it's really important that actually we are still giving our patients essential medications. Always check the BNF when prescribing the older people. There's often a reduction in the dose and adjustment for renal or hepatic function. So have you measured the EGFR of your patient? If we're going to stop any medications, when, what and by whom, one of the joys that I have of working with older patients is actually releasing them from their torture of having to take 20 or 30 different medications by explaining to a 90-year-old that their cholesterol level and their statin use at the age of 90 or 95 is probably not overly important. Remember the basic premise that clinical trials are not done in older people. So when we do clinical trials, as you know, they are done in people of your age or fit, healthy specimens who can tolerate the drug. And we don't do, as you can imagine, randomized controlled trials in people who are in their 90s. Therefore, you have to question largely about how useful these drugs really are in older people. In older people, there is altered pharmacodynamic and pharmacokinetic behavior, as you might imagine. There's increased risk of drug interactions. Again, you will find these in the BNF. Opioids and benzodiazepines have an enhanced potency in the elderly. So this is really important. So, for example, if you give someone who's older 2.5 milligrams of morphine, you're actually in reality probably giving them 5 milligrams at least of morphine, which could have much more of a significant effect on them than your original intention of giving them 2.5. Similarly with benzodiazepines, so typically in the older person, especially if I'm using IV benzos, I'll only use 0.25 to 0.5 milligrams of midazolam IV. There's a smaller volume of distribution as patients have often lost their adipose tissue, skeletal muscle and so on, so there's a higher plasma concentrations for IV bolus drugs. The effect to site delivery can be delayed, so there's a real risk of iatrogenic overdose. So bearing in mind that morphine can take up to 30 minutes to work, certainly I wouldn't encourage giving you give the patient to be given 5 milligrams of IV morphine and then 2 minutes later giving them another 5. They are likely to get the whole effect of 10 very quickly and could of course stop breathing. So there are problems with opioids and sedatives, so problems due to reduced clearance and prolonged action of drugs. So drugs like opioids and benzos, if given recklessly, can cause airway obstruction, hypoventilation, hypotension, somnolence and delirium. Benzodiazepines may slow mental recovery, so you also have to be careful of things like haloperidol, which can cause bradycardia and QT syndrome. So you have to be very careful in prescribing hypnotics, for example. Tramadol I avoid at all in all people, but especially the elderly, because of the risks of falls and so on. So golden rule for you when prescribing the elderly, remember the volume of distribution of morphine is roughly halved in the elderly, doubling plasma concentration for a given dose. So I've got a final slide, is a bit of recommended reading for you. Geriatric Medicine at a Glance 2015, edited by Blundell and Gordon, by Wiley Blackwell, and Acute Medicine in the Frail Elderly 2013. And I'm going to plug another book that I've recently bought called Geriatric Emergency Medicine, Principles and Practice, edited by Khan, Margaran and Olshaker, and that's produced by Cambridge Medicine. As always, any questions you can email me at james.piper@ucl.ac.uk, and I wish you all the very best.